All right, good morning. My name is Kerry DeGroot. I'm the professor and chair at Georgetown University Hospital, MedStar Georgetown University Hospital in Washington, D.C., and I have the honor of moderating the Basics in Heart Failure Talk Curbside consult with the experts, and we have quite a panel of experts. I saw them last year, so I know their presentations are great. We're going to look at heart failure in patients undergoing non-cardiac procedures. That's the goal here. So I'm going to start out with Dr. Sanjay. He is a professor of anesthesiologist at the University of Kentucky. He is the division chief of cardiac anesthesia and the founding professor and director for the Adult Cardiac Thoracic Fellowship there. He has interest in healthcare economics and the evolution of cardiac training, cardiac anesthesia training. So Sanjay.
Thank you, Dr. Greer. So I'll begin this panel with left ventricular heart failure. What's new, what's old, what's correct? And welcome everyone to San Antonio. It's good to see many faces on a Tuesday morning, afternoon. Nothing to disclose. So I'm going to briefly talk about classification of heart failure and discuss physiology, and most importantly, give you an idea of the guidelines. I'll talk kind of like superficially just to set the stage and help your thinking, and there's always more to read and get into the depths. And as you all know, at a definition level, heart failure is a complex clinical syndrome that occurs not only from impairment of ejection of blood, but it could also occur because of impaired ventricular filling. It's important to understand the stages of heart failure. That's what guides the management of these patients, and it helps us understand the progression of this disease. So it goes from stage A, B, C, and D. It's important to note that these patients are symptomatic. Once they're symptomatic, they fall into the stage C and D category. So in stage A, they are at risk for heart failure. They don't have any symptoms. Maybe they have like hypertension. And then they go on to stage B, where there's something wrong with the heart, but there's no symptoms yet. And then they become symptomatic, which is when they fall into stage C and D, as you can see. Now, you all know and heard about New York Heart Association classification. This is more to characterize their symptoms and functional capacity. And at this level, they're already symptomatic. They're in stage C or D. And as perioperative physicians, it's important for us to know their activity level and functional capacity, because even though they are in stage C or D, their functional class can vary from class 1, where they have no limitations and activities, to class 4 with limitations and activities. So maybe they presented in the pre-op clinic and they're all fatigued, but 2 weeks before they were able to exercise or mow their lawn, then that's a change in the clinical status, which should trigger suspicion for worsening heart failure. So they can toggle between class 1 to 4. How is it classified? So we have the heart failure with reduced ejection fraction. These patients have ejection fraction less than 40%. And then we have the patients with heart failure with preserved ejection fraction, where the EF is more than 50%. Typically, these patients have diastolic dysfunction, which means they have poorly compliant left ventricle, which means they have elevated filling pressures. And we have to have some evidence of increased filling pressure, which could be obtained either by echo or elevated BNP or invasive testing. What if the EF is between 40 to 50%? There's a lot of debate about it. Long story short, these patients will be categorized under the category of mildly reduced ejection fraction. This is just an epidemiology slide, just to give you an idea as to the prevalence. Just the take-home point is that the prevalence is worsening. Patients with heart failure with preserved ejection fraction, they almost comprise 50% of the total heart failure patients. This is a heat map. That's what the data analytics say. Red is bad, highly prevalent. I live in Kentucky. You see a lot of red. We're always in trouble. Um, just a quick review of physiology, just to help us understand how the two differ, the heart failure with reduced and preserved ejection fraction. If you look at the pressure volume loop, the LV will fill during diastole, and then systole starts, blood is ejected out, and then finally at the end of systole, the aortic valve closes, and that is your end systolic pressure. If you take the same heart, let out the blood at less volume, then it will generate less end systolic pressure. If you put in more volume into the heart, it's going to generate a higher pressure. The bottom line is, if you join these end systolic pressure points, they all fall on a slope, on a line rather, and the slope of this line gives you an idea of the contractile state of the heart. And that contractile state is reduced in patients with reduced heart failure with reduced ejection fraction. Same heart, if you put some epinephrine, increase the contractile state, the slope will be better. Compare that to patients with pure heart failure with preserved ejection fraction. They can coexist, but if they have only heart failure with preserved ejection fraction, typically these patients have increased LV pressures for a given volume, which means that can translate into increased left atrial pressure and pulmonary edema, and hence the symptoms of dyspnea and as such. It's just a basketball analogy. That's what I tell my resident. Heart failure with reduced ejection fraction is like an air ball, not enough force. Preserved ejection fraction, they're not able to receive it. So the rest of my the next 10-15 minutes, we're going to talk all about the intracellular signaling pathways and the hormonal mechanisms. No, we're not. How are these patients evaluated? As perioperative physicians, we may not always be involved in their diagnosis. However, we need to know the basis of their diagnosis and management. Obviously, clinical evaluation is the key, but for us, it's important to keep the top 3 etiology for heart failure. One is ischemic heart disease. Patients with coronary artery disease, the relative risk is almost 8 to 8.5. And then there's a long list of etiology for heart failure. And then EKG lab evaluation is done to look for end organ damage. The one thing I would like to draw your attention to is BNP levels. Typically, once the diagnosis is suspected, BNP levels are done. It helps us, if the BNP levels are elevated, it may be because of heart failure, it may not be. However, it has a good negative predictive value in the sense that if it's normal, then it's unlikely that the patient has heart failure. A lot of non-American societies, like Canadian Society, use BNP levels perioperatively, especially if the patient has a high risk. If you're suspecting heart failure in a perioperative situation, get a BNP level. If it's elevated, it is what it is, but those patients move on to get troponin levels in the perioperative period. Further evaluation of these patients, once a diagnosis is established, involves echocardiography, as you can imagine. And there are other testing like MRI, CT, and radionuclide. I'm not going to go into details of that. Invasive evaluation of these patients are typically reserved in acute situations. For example, they are having an ischemia and they may need coronary angiogram. So artificial intelligence is now evolving in every aspect of our life, as you know, and it has definitely evolved quite a bit in heart failure. I'm not going to go into the details, but it's worth noting that machine learning is not a new concept. As you can see the timeline, it's always been there. However, with data now available, the machine learning can analyze the data, look for patterns, and make recommendations in terms of either prognosis or identification of or diagnosis of heart failure, especially in remote access areas. In the past, the only reason it did not evolve was the data. As you all know, we had paper charting, but now it's all electronic. So with the advent of data available and the machine learning available, AI has evolved quite a bit. At various stages of heart failure, AI is now being used either to diagnose in remote areas or to prognosticate or to manage their treatment. So let's look at how these patients are managed. So the guideline-directed medical therapy, that's the buzzword, is what forms the basis of managing these patients. And that revolves really around what stage they are at. So in stage A and B, as you know, they are not symptomatic. In stage A, they just have the risk factors, so obviously it involves managing their risk factors in terms of promoting healthy lifestyle habits. And there's stage B, they're still not symptomatic. And at this level, it really involves on managing their underlying comorbidities, such as maybe coronary disease. These patients can have reduced ejection fraction, and there are some class 1 recommendations, but I'll move on and talk about it. So stage C and D is when they're really symptomatic, and the pharmacological therapy becomes very important at this stage. However, we need to know whether they have heart failure with reduced ejection fraction or preserved ejection fraction. There's difference a little bit with the management guidelines. There are four really class 1, there are 4 groups of medications that are class 1 recommended in these patients. So one is angiotensin receptor neprilysin inhibitor. You may have heard the trade name Entresto. It's a combination of 2 medications. One is sacubitril. It prevents the breakdown of natriuretic peptides, so that helps promote diuresis. And it's combined with valsartan, as you know, it's an angiotensin receptor blockade. That's one important class of medication. And then you have the sodium glucose transportase 2 inhibitor. This was developed initially for diabetics, but then in heart failure patients, it has been shown to promote remodeling and also reduce hospitalization. And then there are other 2 classes of medications, beta blockers. Not every beta blocker is recommended. The ones that are really recommended as class 1 is bisoprolol, carvedilol, or sustained release metoprolol. And then you have the spironolactone or eplerenone. Eplerenone is a newer medication we see a lot in our own institute. It has less side effects, more effective. So once again, what it means to us as anesthesiologists is if you know the patient has reduced ejection fraction or has a diagnosis of heart failure, and if you don't see these medications, maybe it's worth triggering a cardiology consult. We also need to know that some of these agents have their own side effects. For example, sodium glucose transportase 2 inhibitor is known for its normoglycemic ketoacidosis. Now, there are some other couple agents, ivabradine and vericiguat. So they are second-line agent. Ivabradine is usually, it helps reduce the heart rate in patients who are resistant to beta blockers. Vericiguat is a guanylyl cyclostimulator. It's a class 2B recommendation. Couple of the important points is a lot of these patients will have ICD implanted when they have reduced ejection fraction, known to prevent sudden cardiovascular death. So perioperatively, we need to know how to manage these ICD. Or they may have a cardiac resynchronization therapy, which is essentially stimulating your LV and RV in a synchronous pattern that also has helped to improve their symptoms. And lastly, we need to know what not to give in these heart failure patients. They are class 3 recommendation in the sense they can create harm. Calcium channel blockers, NSAIDs are an important group of agents to keep in mind. So the last thing is the heart failure with preserved ejection fraction. Here, the treatment really, there's not a lot of class 1 recommendations, but the treatment really revolves around, number 1, underlying their comorbidities, hypertension, for example. And as you know, these patients have elevated LV pressures, which can translate to pulmonary vasculature, and they can have dyspnea, so diuretics play an important role. Sodium glucose transportase 2 inhibitor is also recommended in these patients as a class 2A agent. And atrial fibrillation management is extremely important because that atrium is at a very high risk of going to fibrillation. And then stage D, Dr. Promise earlier, you're going to talk a lot about advanced heart failure. So what are some of the take-home big picture messages? Heart failure really encompasses from reduced ejection fraction to preserved ejection fraction. They can coexist, very important. Patients with heart failure with preserved ejection fraction have increased left atrial pressures. Guideline-directed medical therapy, that's the cornerstone of the pharmacological therapy for these patients. The newer agents, now they're not very new, but relatively newer are sodium glucose transportase 2 inhibitors and angiotensin receptor neprilysin inhibitor, and we still have our older agents, beta blockers, and ARBs. That's it.
Next, we have Dr. Melissa Bellamy. She is an assistant professor of anesthesiology and critical care at UT Southwestern, just up the road. She serves as the assistant director of critical care fellowship and the patient safety director. Her academic interests include medical education, right heart failure, mechanical circulatory support, and transplant anesthesia. Melissa, Dr. Bellamy.
Thank you for that introduction. I promise I will not be able to do the right heart justice in 12 minutes, but bear with me. I will do my best. Okay, let's see here. Maybe. All right. So today we're here to talk about the right heart, what to respect physiologically, what to do when things go wrong, and what to avoid. So sadly, I have no disclosures. There we go. Okay, so very quickly going through the learning objectives. Hopefully at the end of this talk, you'll have a little bit better understanding of the physiology of the right ventricle, can talk through a few reasons why the right ventricle might fail and what to do if it does. So quickly, the outline, we're going to start off with physiology. The right ventricle is different from the left ventricle in so many ways, morphologically and physiologically. The right ventricle is a thinner chamber. It lives in a low-pressure environment. The job of the right ventricle is to take blood from the venous system and to pump it into the pulmonary circulatory system, which in most people is a much lower pressure and doesn't require as much muscle. Interestingly, the right and the left ventricle share the interventricular septum, which is morphologically left ventricle and is very strong, and can contribute up to 40% stroke work of the RV when conditions are right. So this is our donut model here, looking at a cartoon of our parasternal short axis view. We have our left ventricle. Let me see if I can get my cursor to go to, there we go. So we have the left ventricle here. It is thick, it is beefy, it is round, versus our crescent-shaped thin right ventricle. And I want to draw attention to how the fibers are arranged. So we have concentrically arranged myofibers in the left ventricle, and that allows the LV to beat in a ringing motion to pump blood into that higher pressure systemic circulation. Versus the right ventricle here has longitudinally arranged myofibers that allow the right ventricle to beat up and down like a piston. This makes it a little bit more susceptible to changes in afterload, which are demonstrated here. This is a graph from the 1980s, but physiology doesn't change. So here we have the afterload on the x-axis and stroke volume on the y-axis, and how the right ventricle compares to the left ventricle with increases in afterload. So you'll see the LV as we increase afterload from 100 to 140. There's only a modest reduction in stroke volume, about 15% or so, versus the right ventricle, as you go from 10 to 30 on the afterload, there's a 30% reduction, a pretty steep decline in stroke volume, and that just demonstrates the differences in function from the left and the right ventricle. So if you take nothing away from this talk, I want you to remember the interventricular septum. I feel that initially when we're learning about heart failure, the septum does not get enough respect. The left and the right ventricle live together. They both share the interventricular septum within the pretty constrictive environment of the pericardium. And so pressures are transmitted across the septum. The septal position not only determines its contractile function, but also the filling of the left ventricle and ultimately the systemic cardiac output. Again, I'm racing through this, I apologize. This is an amazing review article. It was an invited review in the New England Journal in 2023, and it goes through all the details, starting with the history of right heart failure, the management, and then long-term prognosis. There's a plethora of amazing figures that are just too busy for a PowerPoint presentation, but this is their approach to the evaluation and initial management of a patient with right heart failure. And I'll do my best to break that down. So initially, when you're evaluating a patient, you're worried about their right heart, you're going to do a physical exam, you're going to see distended neck veins, peripheral edema, some tricuspid murmur. If that tricuspid regurgitation is really bad, they may have a pulsatile liver or ascites, and all of these things make you a little bit worried, so we're going to put monitors in, right? And you can look at the CVP. I always encourage my residents, do not look at one number and tell me anything about this patient. I want you to look at a trend, or in this case, you can also look at the waveform. So over here on the left, you have a normal CVP waveform. And then when patients develop right heart failure, oftentimes there's accompanying tricuspid regurgitation. And that brings the V wave up, eliminates that X descent. So if you start to see a CVP waveform that looks like this one here on the right, that should alert your senses that maybe that something is going on with this patient's right heart. Now, a better dynamic measure of RV function is something called the PA pulsatility index, or the PAPI, like Big Papi. And this is a dynamic function because it looks at the pressure the right ventricle is able to generate. So it looks at the PA systolic minus the PA diastolic. So yes, this does require a PA catheter, and divided by the starting pressure or the right atrial pressure. And it's validated in 2 different populations. I've covered them up with Big Papi here. But if the PAPI is less than 1, in patients that have been studied with acute MI, that portends right heart failure. And then I'm going to draw up a study that was done in Boston to follow the theme here up at Tufts in patients undergoing LVAD. And they measured the PA pulsatility index both before and after surgery immediately and then 24 hours later. And they found patients who had a PA pulsatility index of less than 1.85 had a decrease and a sustained decrease in their RV function postoperatively after LVAD placement, as compared with those who had a PA pulsatility index of 2 or greater. They did have an initial decline in RV function, as we all see in these patients, but it recovered afterwards. So what are we going to do? The stethoscope is slowly being replaced by point-of-care ultrasound, for better or worse, and we can just put a probe on the patient and see what we're dealing with. So very quickly, I want to talk through this apical 4-chamber view here. We have a cursor that's somewhere. Anyway, everyone can appreciate this is the right side of the heart, the left side of the heart. Classically, the right side of the heart is smaller than the left. These appear to be about the same, so we know there's some form of dilation. And the quick way to grade this is if the RV does not contribute at all to the apex, it's mild dilation. If it shares, as in this patient, moderate dilation. And if the RV forms the apex, that's severe dilation. Over here, I want to draw your attention to the septum. This is our short axis view. I hope everybody can appreciate this is a ginormous right ventricle. And we have flattening of the septum primarily in diastole, which portends volume overload in this patient. But what about measures here to tell us about RV function? So we're going to ignore the TR maximum velocity and focus over here on the left side of the graph. This is something called a TAPSE, stands for tricuspid annular plane systolic excursion. What you do is you take M mode and put it through the lateral part of the tricuspid annulus, and you measure the movement up and down. You really engage that piston-like movement of the RV to estimate function. And anything over 1.7 or 17 millimeters is indicative of normal RV function. All right, so we're going to break down the causes of RV failure into problems with preload, problems with afterload, and problems with contractility, just like we do for the left side. Anything that is regurgitant can cause increased preload, and then anything that connects the left and the right of the heart as they shouldn't be can cause increased preload and lead to RV failure. Increased afterload, this is what we're commonly seeing in the operating room, so pulmonary hypertension, patients with acute or chronic PEs, and then in our pediatric population, pulmonic stenosis and RVOT obstruction. And then things that cause decreased contractility, classically right-sided MIs. We're supposed to talk about non-cardiac surgery, but in cardiac surgery, if you have an air embolus, you take air coming off pump, it's going to go down the most anterior route because bubbles float up, go down the RCA, cause some right-sided dysfunction transiently. Cardiomyopathies, dysrhythmias, and sepsis can all cause some decreased contractility as well. So why do we care about right ventricular failure? And this is why. There's this thing called the spiral of death, and we'll use increased RV afterload. Let's say that we have a patient with an acute PE, and so an abrupt increase in pulmonary pressures in a patient that has an otherwise normal physiology, a thin right ventricle that's not used to that. It's going to dilate out very quickly. That's going to cause TR. It's It's going to cause further volume overload, increased wall tension, which we all know causes the secretion of ANP and BNP, and our bodies retain more salt and more water. There's inflammation of the myocardium. All of this increases oxygen demand, causes further ischemia. If we didn't already have decreased contractility, ischemia does not help contractility, which decreases our RV output. RV can't pump over to the left side, so we have decreased preload on the left side, decreased systemic cardiac output, therefore hypotension. If we weren't ischemic earlier, our coronary perfusion goes down when we're hypotensive, leading to further ischemia, decreased oxygen delivery, and very quickly hemodynamic collapse. As if this wasn't scary enough, something is missing. And we talked about the septum earlier, and I told you I was going to drive this home. So actually, as early as the very beginning of this spiral, when that RV starts to dilate out and the pressures on the right side increase, it's going to push the septum from the right to the left, and very quickly you're going to end up here with decreased preload on the left side and decreased systemic cardiac output. So it's important to intervene early. And this is just the same picture we showed earlier. All right, so let's get into management principles. I am gonna have to fly. So this is a consensus statement from the AHA. It is wonderful, it is busy. I'm gonna break this down for you. Management principles: it is important to keep afterload high, to optimize preload, which almost always means taking volume off, reduce RV afterload, that is pulmonary pressures, and maintain cardiac output and contractility. So starting with afterload. It is important to keep afterload high so we perfuse our coronaries, and we keep the septal position midline. If you increase the systemic pressures, that's going to increase the LV systolic pressure and kind of encourage the rightward movement to normalize that septal position. We do so, vasopressin is the best drug to achieve this goal because it doesn't affect pulmonary pressures, but oftentimes vaso, we're limited, can't really go above 0.04, need to add something else. So I recommend using norepinephrine because as opposed to phenylephrine, it has some beta agonism. Optimizing preload, like I said, these are the patients that we're going to be dealing with in the operating room. So our stroke volume is already kind of fixed in patients that have high RV afterload. Therefore, it's important to take volume off because it only hurts us. And these are those patients. All right, reducing RV afterload. Like I said, this is PA pressures. We have some low-hanging fruit. Make sure you avoid hypoxia, hypercarbia, acidosis. Use normal tidal volumes, lung protected ventilation. I think we're all doing this now already. And then this is the internal milieu of a patient with pulmonary hypertension, and there's 3 pharmacologic targets. So endothelins are vasoconstrictors, prostacyclins are vasodilators, as is nitric oxide. And these are all of our pharmacologic targets. We may see patients on bosentan. This is an oral endothelin antagonist, causes decreased vasoconstriction. And then in the operating room, what we are using the most are inhaled agents, nitric oxide and epoprostenol, which cause pulmonary vasodilation. Okay, maintain cardiac output and contractility. Keep these patients in sinus rhythm. Atrial kick is especially important, and they need to be on the higher side. Just like in our LVADs and transplants, we keep the heart rate up. RV failure, with that fixed stroke volume, you have to really leverage the heart rate times stroke volume part of that cardiac output equation. Epinephrine's the best drug, but there are inodilators, dobutamine and milrinone. Dobutamine is fast on, fast off. Milrinone, you get around for about 6 hours. My mentor always said you date dobutamine and you marry milrinone. So if you get vasoplegia from milrinone, it may stick around. You're probably going to have to pair it with vasopressin. And I'm sorry to race through this, but we have to get to the next part of the talk, which is mechanical support. And if all of these medical management therapies are not enough, we need to learn what other options we have. Here are our main points. And thank you for bearing with me.
Thanks, Dr. Bellamy. A whirlwind tour of the right heart. Thank you. Our next presenter is Dr. Promise Arroyo. She's Assistant Professor of Anesthesiology and Critical Care at Johns Hopkins. She is the Director of Clinical Quality and Patient Safety for the Division of Cardiac Anesthesia, and she brings perioperative optimization, and advanced circulatory strategies. Thank you, and I'm sorry you're 12 minutes.
Oh, yeah.
Pressure's on.
Oh, I did that wrong. Clear.
The repeat button?
Yeah. Thank you.
That's all right. You can go ahead. I'll get you started.
Thanks for the introduction. If you think Melissa spoke fast, you are in for a treat. So, in the interest of time, I'm going to go really fast. I will be talking about circulatory support for heart failure. Are machines the answer to everything, or are they merely a trap? I will refer to circulatory support as MCS, just to save on words. I have no disclosure. And I hope that by the end of the 12 minutes, you're able to identify and describe some common types of MCS, know the indications and contraindications, understand some hemodynamic profiles, and be able to discuss some drawbacks to some of these devices. So we talked about meds. They have a ceiling effect, and sometimes there are just too many side effects to continue to use them, and we have to think of something else. So MCS are devices that help us improve forward cardiac flow and help with tissue perfusion. Some of them have the options of, Some of them have the option of providing gas exchange, and importantly, an ideal MCS will allow for myocardial recovery. Speaking of, we know it's all about demand and supply. I do not want to underestimate the importance of myocardial recovery. We want coronary perfusion to be maintained, which is a function of our blood pressure, and that pressure in the left ventricle, as was described earlier. And the demand is a function of many things, but in this case, the wall stress. Back to physiology, wall stress is a function of how dilated the LV is and the pressure, again, in the LV. So you want to maintain good coronary perfusion, you want to decrease the LV wall stress. Keep that in mind. Well, why do you care about MCS? You care because your patient may need MCS, or you may be asked to take care of a patient that already has one. This is just an ELSO registry database showing an exponential increase in both the number of patients receiving MCS and the number of centers providing them. There are all kinds of devices, and we're not going to be able to talk about them all today. Suffice it to say, there are permanent or durable devices, mostly known as LVADs, and there are temporary ones, which I'll focus on. We have temporary devices for the right ventricle, and we have temporary devices for the left ventricle, and we'll talk about a couple of those. Another important point I want you to take home is these are temporary. They are not meant to be a bridge to nowhere. So when you're thinking about the indications for these, you should be asking yourself, is my patient likely to recover? So is this going to be a bridge to recovery? Is this a possible bridge to a durable support like an LVAD? Or maybe they're a candidate for transplant if this doesn't work. We don't always perfectly identify the right candidates, but you want to be reasonable. So you probably don't want to call a consult for an 85-year-old with advanced metastatic cancer who is very frail and have poor prognosis, because it's a labor intensive and they don't always work. Having said that, let's talk about a couple. The intra-aortic balloon pump is very popular, and it's percutaneously inserted through an artery, usually femoral or axillary artery, and it's positioned in the descending aorta. It's a counterpulsation device, meaning that during systole, it deflates, and during diastole, it inflates. The timing of the inflation-deflation is synchronized with either the EKG or the aortic pressure that has a sensor to it. So with inflation and diastole, it raises the afterload, raises the diastolic blood pressure, and therefore helps coronary perfusion, like I showed you in the equation earlier. In diastole, it deflates, decreasing the afterload, and therefore augmenting cardiac output, not by a ton, just about half a liter, and relieving wall stress. So this is commonly used in shock, in MI, for all the reasons described, to support surgery, to support PCIs. There are some drawbacks and contraindication, including bad peripheral vascular disease, aortopathies, and aortic insufficiency. These are the limitations. Again, it's not a lot of volume. You can't use it if you're as well if you're tachycardic because you're not spending enough time in diastole and not optimizing coronary perfusion. There are vascular complications that could happen. Moving on to the Impella. This is more physiologic in that it mimics the natural pathway of blood from the heart to the aorta. So it's a transvalvular pump, and it sucks blood from the LV and deposits it into the aorta. It's univentricular support, and it comes in different sizes. Some can be placed percutaneously and gives you a couple of liters of flow, but you could also have one placed surgically through a cut down and can provide up to 6 liters of flow. This illustrates what I mean by intraventricular pressure and being able to offload it. So this is a heart that's very distended and has a lot of pressure in it. And if you look to the valve on the to the graph on the right, the red graph is the LV pressure, and the green line is the aortic pressure. To the left, you have one that's failing before Impella is placed, and to the right, you can see that both the peak LV pressure and the diastolic pressure in the LV are reduced while you're able to maintain a mean arterial pressure. Contraindications, bad valve, stenotic, insufficient, you don't want to use it. If you have a clot in the LV, clearly you don't want to do that. You don't want to suck clots from the LV into the systemic circulation. They are at risk for malpositions, and with any of these pumps, there's risk for bleeding and hemolysis. Just so you know, there's a right-sided Impella. Remember how I said that's univentricular support? This is univentricular support for the RV, and this was authorized for emergency use during COVID and has remained with us. ECMO. ECMO is like the cardiopulmonary bypass without the reservoir. So you draw blood from a central venous circulation, you put it through an oxygenator, and you pump it back into a central arterial circulation. To the left is central ECMO. We tend to use that mostly in the cardiac OR, so you don't have to worry about that so much. To the right is what we call peripheral ECMO, where you're drawing blood from the IJ or from the femoral vein, putting it through the ECMO machine and returning it to the femoral artery. This provides support for the ventricles, and it provides gas exchange, and it has a whole host of indications, including heart failure, massive PE. You can use it for eCPR when someone codes and you don't get ROSC in reasonable time. You think they're a candidate, you can think early and call for ECMO. There are multiple indications and contraindications, but there are also complications with it. Just like the other ones, we have bleeding, we have thrombosis, strokes. But I want to bring us back to this LV distension talk again. This is a retrograde flow into the arterial system. So imagine a failing heart, and you put a big cannula into the femoral artery, and you're pumping, I don't know, 4 or 5 liters of blood into that aorta. That's a lot of afterload for the LV. So while you're supporting the rest of the body, you are not necessarily supporting the heart, because this heart has a lot of volume, is very distended, and is very stressed. And the ability to recover is going to be minimized, but you have circulation. Some of us think we're good, but we're not really good in that sense. The graph to the right is another pressure volume loop showing you in blue what this heart could look like. Again, you have high pressure and high volume, not good. But as you add ECMO support and you crank up the flows, say from 3 liters to 4 liters to 5 liters in the green curve, you are increasing that afterload, but you're also seeing an increase in the left ventricular volume and the left ventricular pressure, which could be very devastating to myocardial recovery. And what happens when, when you don't eject blood? This happens. That's a lot of stasis in the LV. And if this patient ends up forming clots, you know they are gone. There's no recovering from this. Less scary is, just all the the backflow of blood that happens into the pulmonary system, and just really bad pulmonary edema that could lead to Harlequin syndrome, that could lead to really difficulty weaning this patient from the machine. There are multiple ways to decompress the heart. You can give vasodilators, you can up your inotropes, you could put in a balloon pump, there's surgical venting, and there is percutaneous vents such as the impeller, and that's where the term impeller came into being, where you have peripheral ECMO, so you're supplying blood in a retrograde fashion through the femoral artery, but concurrently you have an impeller through the aortic valve that's able to decompress and offload the heart in that situation. And this is just an example that there are studies showing that timely offloading of the heart, especially around the time of initiation of ECMO, can actually make a difference in survival in patients placed on ECMO. So what is the ideal MCS? We don't know. There are suggestions that the impeller is better than the balloon pump. There are suggestions that maybe ECMO is okay if you vent them on time. We don't have robust, we don't have randomized control trials or robust trials to identify the ideal support, but what we do know is that you want to be able to think carefully, and based on the patient phenotype, based on your operator experience, based on the resources, your institution, and hopefully utilizing what we call a shock team, you can come together and decide what the patient could benefit from using very well thought through algorithms. And this is just showing that institutions that use shock teams do better, they have better outcomes, and this is usually multidisciplinary with, surgeons and anesthesiologists and ICU docs, and they usually have better outcome. So take-home point. Medical management is still first-line therapy, so don't ignore everything my colleagues just told you. But when you are escalating doses or you're starting to see really bad side effects, you want to consider MCS. You want to make it a multi-D conversation. You want to think about it early, and shock team is the way to go. Thank you.
Thank you very much. That's another whirlwind tour. That's awesome. Finally, we have Dr. Scott Heller. He is an assistant professor and director of clinical operations for the Heart and Vascular Institute at West Virginia University. He has done a lot of work on perioperative care in collaboration with our ICU teams. Thank you, Scott.
Hello, everyone. Thank you for having me today. So I'm going to talk about predominantly how we can avoid all the things that my colleagues just talked about. And that's predominantly going to be through preoperative planning and optimization of the patient before they ever hit our ORs. I have no disclosures, unfortunately. So I'll talk a little bit about heart failure, though they've already talked about that significantly, and then what we can do perioperatively, preoperatively, in planning as far as to make it as safe as possible for our patients, reduce morbidity and mortality associated with heart failure. So there was a recent guideline release actually during ASA last year as far as perioperative management and optimization for patients with heart failure undergoing non-cardiac surgery. And so that's predominantly the things I'm going to try to touch on and changes that have recently been suggested. So like my predecessor said, heart failure is a clinical diagnosis. There's no single diagnostic test, and it's extremely varied in how it can present and the causes of patients having heart failure. There's both systolic and diastolic heart failure, and oftentimes they do exist concomitantly. Also, just like they've said previously, AHA staging is the classes A through D. We predominantly look at more, once you've diagnosed heart failure, what's their functional capacity? And that's what we're often asking about preoperatively is what can they do? Has that changed significantly? As that can be a good indicator for are they as well managed as they possibly can be before they undergo surgery. And so there's been several trials and retrospective analyses of patients undergoing non-cardiac surgery, specifically ambulatory procedures, including one in 2019 that looked at over 300,000 patients and showed heart failure, if you have it and you undergo non-cardiac surgery, you're at increased risk of mortality and complications, whether you're well treated or not, although it's much worse if you're not optimized before undergoing surgery. There's a 2 times increased adjusted odds of mortality at 90 days. As well as increased odds of complications in patients who have heart failure, and that includes patients who have preserved ejection fraction heart failure. And so what can we do to try to mitigate that risk? One of the best things we can do is use some of the perioperative risk calculators to try to determine if patients would benefit from further workup and optimization before they undergo surgery whatsoever. And that's best achieved in a preoperative clinic where you have time to make an intervention before they undergo surgery, as surgery itself also has some risk associated with it, different surgeries being more risky than others. And so that starts with us seeing the patients, specifically hopefully an anesthesiologist or APP working for anesthesia that is able to assess the patient, determine where they're at as far as their baseline, and what kind of symptoms they have from their heart failure. And has that changed recently, or since the last time they saw a cardiologist, if they see one at all, have they had significant changes in their exercise capabilities? The most common perioperative risk calculators, there's several out there. RCRI is by and far what we use the most. The reason why is it's simple versus NSQIP, which actually has a better predictive value for patients as far as morbidity, mortality, and undergoing surgery. However, that's a 21 component test, which is a little bit difficult to administer to someone, whereas RCRI is pretty simple. It looks at 6-point values, including ischemic heart disease, previous stroke, heart failure, insulin-dependent diabetes, CKD, and the surgery type itself. And then based on those, determines what kind of risk the patient is at and whether perioperative assessment would be indicated. So any individual with greater than 3 points that hasn't had an EKG or a TTE or anything in the last year, hasn't seen a cardiologist in that time, hasn't been put on goal-directed medical therapy, would benefit from consideration of those things. This table on the right is a little hard to appreciate on here, but that's in that 2024 guidelines, and it has a stepwise approach to looking at what have they had done previously, what medications are they on, what's their current functional status, and based on those, recommends should they have a TTE currently, should they have an EKG. Generally speaking, anyone with heart failure that hasn't had an EKG recently almost always should, if nothing else, just for comparison perioperatively and postoperatively. TTE should be a little bit more judiciously utilized. Patients specifically that have known valvular abnormalities, haven't had a TTE recently, or have high-risk things like HOCM are better utilizations of that. Recently, in the 2024 guidelines, they actually recommended it's reasonable to obtain a BMP and or a troponin preoperatively, and this isn't to determine whether they should undergo surgery or not, but rather to establish a baseline that where they currently are at now, to establish where they land after surgery, especially if there's concern that they may have had a cardiovascular complication, to be able to determine what implications that's had upon the heart itself. And they also recommended, if capable at your institution, that an N-terminal BNP might be more sensitive versus a standard BNP. I only briefly want to talk about cardiac implanted devices, as that's a huge topic, but there were guidelines or practice parameters that were released in 2020 by the ASA about appropriate management. We all know these patients are much higher incidence of having these devices and should know what to do as far as interrogations and management of them in the perioperative theater. A recent change in 2024 was the recommendation and distinction between acute coronary syndrome versus chronic coronary disease and the management of dual antiplatelets in those patients. So patients that had a drug-eluting stent placed for acute coronary syndrome are recommended to wait at least 12 months before interruption of their dual antiplatelets versus those that were found incidentally with chronic coronary disease and drug-eluting stent placement. It's reasonable to wait only 6 months. Anyone who has time-sensitive surgery, they make this kind of soft recommendation that you could wait 3 months, but it's best actually managed by a multidisciplinary team looking at the risk-benefit and whether time-sensitive is really worth interrupting the dual antiplatelet and increased risk. Anticoagulation falls in the same bucket. So anticoagulation is very common in these patients. Patients who have AFib with no other thromboembolism risk, it's reasonable that they don't need bridging. Patients with mechanical valves, it's absolutely necessary that they have bridging, but anything in between is best, again, managed by a multidisciplinary team, and time beforehand is going to allow to create the safest profile for those patients. My predecessors talked about goal-directed medical therapy. I rather want to touch on what do we do with them perioperatively. So everyone knows beta blockers, we continue in the perioperative theater, and we've had several trials to suggest we absolutely should not institute them in our clinics before patients undergo surgery, as that actually increases non-cardiac mortality, including stroke risk, hypotension, and bradycardia. But if they're already on beta blockers, they should be administered, including the day of surgery. A recent change is going to be in the ACE inhibitors, ARBs, and ARNIs. So those medications previously were always recommended to be discontinued the day of surgery. However, now in the recent AHA guidelines, in patients who have these drugs being given for heart failure specifically, not for patients that are utilizing them for hypertension, it's actually reasonable that they should be continued in the perioperative theater, as the small increased risk of hypotension is not as risky as the increase in cardiac complications associated with discontinuation. So we should continue those if they're being administered for heart failure specifically. The SGLT2s absolutely should be discontinued, preferably 3 to 4 days before the procedure, as they do have an increased risk of euglycemic ketoacidosis if those medications are continued in the perioperative theater. And then other medications, so diuretics are extremely common. Again, those are going to be recommended to be continued. Another uncommon one that we don't see too often, but we should be aware of, is digoxin. There are still patients out there on digoxin. That is recommended to be continued in the perioperative theater, but we should be aware that toxicity, as it is renally excreted, can become a real concern, especially postoperatively. And so we should be aware of those common symptoms and signs associated with toxicity. ARNIs are going to become even more popular now, as they have been approved for heart failure preserved ejection fraction. So we do need to be aware of those medications and their increased utilization and what we do with them perioperatively. As far as intraoperative management, unfortunately, that's where we have the least data. There's very few randomized controlled trials recommending general versus regional or anything like that. So rather, the best thing we can do is make sure that these patients are as best optimized as they possibly can be and seen prior to undergoing surgery, so that we have the time to be able to make interventions, refer them to cardiology if necessary, if they're showing signs of not being at their baseline, or and then be able to make the best possible perioperative strategy, including general arterial catheterization, PA catheters, things like that. But unfortunately, I can't give you any data to suggest one approach over another. Rather, I can only suggest that you should do what you're most confident with and comfortable. So that's where our largest pitfalls are going to be, is actually intraoperative management. So where you can make the biggest difference is optimizing these patients preoperatively. Take-home lessons. Heart failure is extremely diverse. The best utilization is going to be using our risk assessment calculators and using those to optimize the patients, obtain appropriate laboratory and imaging studies beforehand, and referring to cardiology if these patients are deemed to be necessary. Thank you.
Thanks. Thanks our vast experienced panel, our experts. We have time for a few questions. I ask that you use the microphone if you have any questions for us. I'll start off with one. I heard AI in the beginning, and I feel like every step in this lecture, AI could probably help, even with the management of mechanical devices. Do you see AI increasing in our world?
No, definitely, absolutely. One application of AI, at least intraoperative or perioperative, is that hypertension prediction index, for example. That is one evolution from AI, where it analyzes the waveforms and then uses an idea if this patient's going to become hypertensive or not. But there are more applications of AI at a field level, in the sense like in remote access areas. It can recognize patterns that this patient may be going into heart failure and alert the family physicians. So that's where more applications are coming in. Definitely AI is not going to replace any of us, but it's more of an asset or a tool.
Yeah, I see it functioning in the perioperative world, right? The pre-op world. So, anyone else on AI? Questions for everyone? All right, well, it's been a long weekend. You guys enjoyed San Antonio, and thanks to our panel.
Thank you. Thank you.
All right, we finished